And we can also go ahead and start letting people in. And Helen and Pam, I hope you have returned.
Yes, we're here.
Great, thank you. Oh, we'll go ahead and start letting people in. We're doing that now. Welcome to this webinar of the Reproductive Health Supplies Coalition. We will be starting within the next few minutes.
Hi, Sophia.
Yes?
Yeah, Rasa is telling me she's in.
Excuse me?
Rasa is telling me she has joined in.
Yes, yes. Great, thank you. And now everyone is being admitted. Everyone is admitted as they come into the waiting room. And we will be starting within the next couple of minutes. Thank you all for joining us. Welcome to this webinar. We'll be starting in about another minute. Welcome to this webinar. We'll go ahead and get started, and we'll admit others as they come online. This is Sophia Asan of the Reproductive Health Supplies Coalition. We're so pleased that you're able to join us today for this webinar being hosted by the Reproductive Health Supplies Coalition's System Strengthening Working Group. As you can see from your screen, the topic is strengthening medical waste management systems to reduce environmental impact of humanitarian operations. A couple of quick housekeeping notes. You will be kept muted throughout the webinar so that we minimize background noise. Please feel free to enter comments in the chat and questions in the Q&A at any time during the webinar. We will have a good sized Q&A portion at the before the close of the webinar, and we'll have ample time to address questions and comments then. So we welcome your questions and your comments. Now, over the last couple of years, the System Strengthening Working Group, or SSWG, has begun exploring topics that are related to the environment and related to climate change from the perspective of health supply chains. Today, we'll specifically be looking at the topic of medical waste management with a presentation and panel discussion that is led, pleased to say, by Pamela Steele Associates. Focusing on humanitarian livelihood programs and field hospital deployments, the waste in humanitarian operations, reduction and minimization consortium, otherwise known as WORM, of 16 organizations has been funded by the European Union, and it's keen to reduce the environmental impact of humanitarian operations by designing guidelines and support actions moving towards a circular economy. As part of Pamela Steele Associates' contribution to the coalition or WORM's primary objective, they conducted a study on medical waste management in humanitarian settings with an emphasis on field hospitals. They also evaluated existing disposal methods in regular hospitals to understand current practices. And now, before I hand off to our esteemed visitor from Pamela Steele Associates, who will be presenting findings, I would like to briefly introduce to you the panelists and presenters for today's webinar. So today we have Helen Wanza. Helen is an environmental waste management specialist working at Pamela Steele Associates under the Waste in Humanitarian Operations Reduction and Minimization, or WORM as the acronym, project funded by the EU. With a degree in environmental science from Rongo University in Kenya, Helen brings a wealth of experience in conducting research, managing projects, and working with cross-functional teams, stakeholders, and regulatory agencies to promote sustainable practices. She is dedicated to seeking innovative solutions to minimize environmental impact that advance environmental conservation and sustainability, demonstrating a strong commitment to promoting effective waste management strategies. Now, our panel discussion, I am pleased to say, will be moderated by Pamela Steele, who is the founder and CEO of Pamela Steele Associates Limited. Pam is a health supply chain expert from Kenya who specializes in improving access to medicines in Africa. Over the past 30 years, she has worked for several organizations, including Oxfam, UNFPA, and UNICEF, and now leads her own supply chain consultancy. Pam is an executive committee member of the Reproductive Health Supplies Coalition. And she's a strong proponent of gender equality and recently began an initiative called Girls on the Move to encourage more young women to work in the supply chain. Now, we will also have with us 3 esteemed panelists, and I will briefly introduce them to you. We have Stella Kamwasir, who is a senior principal environmental compliance officer in the National Environment Management Authority, currently deployed as the regional director of environment for the Nyanza region, which covers 6 counties, which are Kisumu, Kisii, Migori, Homa Bay, Nyamira, and Siaya. Stella's role currently as regional director is to coordinate environmental management and compliance programs, plans, and activities throughout the region. Her personal interest is in enhancing corporate sustainability and environmental compliance to support a clean and healthy environment. We are also pleased to be joined today by Dr. Frederick Alwatch, who is the Kisumu County Director of Public Health and Sanitation. He is pursuing a PhD in public health at JKUAT and holds multiple degrees, including a bachelor's and master's in public health, an MBA from Maseno University, and a diploma in pharmacy from KMTC. Honored with the State Commendation, HSC, and the Order of Grand Warrior, OGW, for his contributions, Frederick has a notable track record in advancing healthcare, clinical trials, and operational research. He also lectures part-time at JKUAT, impacting the next generation of healthcare professionals. And also, we are so pleased to be joined by Arasha Vina Trufina, who is a seasoned water engineer with a robust background in engineering and a profound commitment to public health. With extensive experience in the water, sanitation, and hygiene, otherwise known as WASH sector, she brings a unique blend of technical expertise and a holistic approach to improving water systems and public health outcomes. Arasha's career is marked by a dedication to developing innovative solutions for sustainable water management, enhancing sanitation practices, and promoting hygiene education to uplift communities and improve quality of life. So these are the folks who we are very pleased to have with us on this webinar. And I'm now very pleased to hand off to Helen Wanza, who will present findings from the study that was conducted by Pamela Steele Associates. Helen?
Thank you so much, Sophia. Hello, everyone. Once again, thank you for taking the time to join in this discussion of strengthening medical waste management systems to reduce the environmental impact of humanitarian operations. I am going to take you through this presentation of medical waste management in humanitarian operations, the findings of Pamela Steele Associates. From the beginning of this year, a consortium of 16 partners, including partners in low and middle-income countries, embarked on a journey to understand medical waste management practices in humanitarian operations under the WAM project. WAM stands for Waste in Humanitarian Operation, Reduction and Minimization. The project is funded by the European Union and has a duration of 2 years. While focusing on the humanitarian livelihood programs and field hospital deployments, WAM is keen to reduce the environmental impact of humanitarian operation by designing guidelines and support actions for circular economy. WAM brings together medical and humanitarian organizations, procurement and logistics service providers, waste management services, and academic partners through a collaborative and a multi-actor approach. This project focuses on 5 key areas. Number 1 is bio-based technological innovation, solutions within humanitarian context, procurement as a gatekeeper for waste avoidance and innovation integration, innovations and improvement in waste management and treatment, sustainable livelihoods of waste pickers, and lastly, policy development and advocacy. As part of Pamela Steele Associates' contribution to the WAM's primary objective, PSA conducted a study on medical waste in humanitarian settings with emphasis on field hospitals and evaluated existing disposal methods in regular hospitals to understand current waste management practices. And according to the 2020 UNECD, over 5.2 million people, including 4 million children, die annually due to diseases caused by medical waste worldwide. This emphasizes the critical health risk of improper medical waste disposal. The World Health Organization estimates that 85% of healthcare waste is non-hazardous, while the remaining portion, which is 15%, is hazardous, which can be infectious, toxic, or radioactive. Poor segregation leads to up to 50% of waste becoming infectious, posing major health risks to the environment and the general public. High-income countries generate up to 11 kg of hazardous waste per hospital per bed per day, whereas in low-income countries, they generate up to 6 kg. Without proper disposal, healthcare waste can infect patients, the workers, and the general public. Injections are a major source of contamination. Over 16 billion are administered annually, but disposal practices are often inadequate, leading to increased risks of diseases like hepatitis B, hepatitis C, and HIV from needle stick injuries. This situation is worsened in field hospital deployment during crisis, where waste management is often lacking, increasing the risk of chemical, biological, and environmental hazards. Pamela Steele Associates engaged different stakeholders in key informative interviews. The stakeholders included humanitarian organizations, waste management service providers, public and private healthcare facilities, and research institutions. From the interviews and site visits in public hospitals, we noted that medical waste is categorized as infectious or non-infectious. In most cases, waste gets mixed at on-site storage before being transported for incineration and final disposal. While healthcare workers recognize the importance of waste segregation, adherence is low due to inadequate resources. In many public hospitals, they lack color-coded bins and liners, often using mismatched or unlined bins. In these public hospitals, they often lack proper infrastructure for temporarily storing waste on site, leading to open and uncontrolled waste storage. Waste is usually transported using basic methods like wheelbarrows, and in some cases, they use trolleys. Waste workers often handle waste without proper personal protective gears. Most of the facilities rely on incineration, but some are transitioning to microwaves with shredders and autoclaves. However, open burning and sanitary pits are still common in some of the facilities. From the key informative interview with Medicine Sans Frontiers, MSF, representing humanitarian settings, we noted that the MSF handles different types of waste, that is pharmaceutical, non-medical waste, and infectious waste, with a high amount being infectious waste. And we noted that health workers, they strictly follow waste management guidelines from the point of generation to the final disposal. And these practices are usually handled by wash hygiene teams who work in shifts. And when a crisis occurs, MSF usually constructs a complete waste management area. And when they have a wastewater that is generated at the facility, they separate it with using grease traps, which is stored in septic tanks or in infiltration systems. When the tanks are full, they are usually emptied and disposed by a validated exhaust machine. When waste from remote dispensaries is transported, they usually use sealed containers via designated vehicles or donkey carts. And when local hospitals lack incinerators, MSF usually collaborate with the Ministry of Health to find a proper company which will finally dispose of the waste. MSF set up drum burners or temporary incinerators in crisis areas. They have introduced the smart ash burner, a high temperature plug and play burner for emergencies, which burn all types of waste, including the sharps. There are challenges that MSF experiences, which includes the rising waste volumes and also lack of coordination between the partners that are usually on ground. These have visual representation of the observed practice in public hospitals. We saw that there are waste management guidelines which are mounted on the walls, but adherence still remains low. Find that waste bins were often uncovered and lacked designated liners, contributing to poor segregation and management of waste. In some of the cases where resources were available, best practices were adopted, such as properly covered bins and the use of appropriate liners, showcasing that adherence improves with better resource allocation. Continuation of the observed practice in these public hospitals, we noted that there are no formal or secure on-site storage facilities for medical waste. Waste is often stored in open or uncontrolled areas within the hospital compound, leading to increased risk and exposure. Both the infectious and non-infectious waste are mixed during on-site storage, posing significant risks to waste handlers and compromising safety of the waste handlers. We also noted that in most of the facilities, treatment and final disposal practices primarily involve incineration and open dumping. The available incinerators have capacities ranging from 50 kg per hour to 100 kg per hour. There's no designated ash pit that was observed. Instead, ash residues are left in the open, awaiting collection and transportation to the dump site. The ash and other residues are dumped without proper containment, increasing environmental and health risks. While most of the facilities continue to use incineration for waste treatment, some are beginning to adopt microwaves with shredders. Even with the shredders, the final shredded waste must be disposed of at a designated site, which adds up to the overall cost of waste management. There's a notable lack of secure on-site storage facilities. Both infectious and non-infectious waste are still mixed, leading to potential health and safety hazards within the healthcare facilities. When we visited the Kenya Medical Research Institute, we noted that the observed practice that we noted is that the facility generated different types of waste, and each of the waste streams undergoes a specific process for waste management. When the waste is infectious, it undergoes chemical dilution, it is autoclaved, then goes to the incinerator. The incinerator has a filtration element which purifies the smoke that comes out of the incineration process. And finally, the residue goes to the ash pit. If the waste is general or non-infectious, it goes directly to the incinerator with the scrubber element and finally to the ash pit. When the waste is This visual show that the same liners are used for different types of waste streams, leading to cross-contamination. The waste that are being dumped openly within the hospital premises, lacking proper containment. Operators, the picture shows operators handling waste and not using personal protective equipment. The waste bins that are not covered, which can lead to spillage and contamination. There's improper storage of sharps, which poses significant risks to health workers and the patients. Then some of the facilities are still using burning chambers, which is an outdated method and environmentally harmful practice. As I was explaining, we visited Kenya Medical Research Institute, and the Research Institute generates different types of waste, and each of them undergoes a specific process for medical waste management. If infectious, it goes through chemical treatment, sterilization through a high pressure steam, that is autoclave. The waste is incinerated with a scrubber element. If it is non-infectious, it directly goes to incineration with the scrubber element and finally to the ash pit. If it is liquid waste, it undergoes through initial dilution with chemicals, then it is further diluted in a sink using water. The treatment then is done through the sewer system. The treated effluent is used for irrigation on farms via sprinklers. This is a visual representation of the observed practice in the field at Kemri. The visual shows that there is proper segregation of different types of generated waste. They have an autoclave machine, which is used to sterilize the infectious waste. We saw that the operators are in full personal protective equipment. The final residue from the incinerator goes to the ash pit. Then there is chemical disinfection. There is proper on-site storage of different types of waste. In their incinerator, they have a high chimney which emits a colorless emission that is not toxic to the environment. Then there is an autoclave, which is used to sterilize the reusable equipment. The incinerator has a filtration scrubber. The filtration scrubber purifies the smoke that comes out of the incinerator. And finally, the liquid waste sewer treatment, which the effluent that comes out of it is used for irrigation using the sprinklers. The following is a summary of the key gaps that we identified. There are no coordinated monitoring and tracking systems for waste management at all stages in the waste management chain. There are limited infrastructural resources and institutional capacity to manage waste effectively. Despite awareness of the dangers, open dumping is still used, complemented by poorly designed incineration methods and burning chambers that are unable to complete combustion. Thus, toxic gases are released, impacting the environment and livelihoods. Waste handlers are hired on a casual basis. They lack professional training. The lack of protective gear exposes them to harmful substances like dust, bacteria, and chemicals, increasing their risk of injuries and diseases as they manage clinical waste collection, sorting, transportation, and final disposal. Government prioritizes often overlook the safety of waste pickers in favor of other hospital staff and infrastructure. There is limited routine training of staff handling the waste. There are no formal training curricula designated for waste management. There is no waste management guidelines specific to field hospitals, despite operations in unique settings. There's lack of clearly appointed individuals to oversee and manage waste procedures. Most of the health facilities do not have waste management budget lines, leading to inadequate supplies such as personal protective equipment, segregation bins, and bin liners. There is limited waste management infrastructure such as on-site transport and storage facilities and treatment technologies. The recommendations for healthcare facilities: they should regularly train and develop the capacity of medical staff and waste handlers. They should implement advanced technological measures for incineration, including filtration and treatment of emissions to reduce environmental impact. They should enforce stricter adherence to waste segregation regulations, ensuring proper separation of waste streams. They should enhance the availability of both on-site and off-site treatment facilities, including recycling centers. They should implement regular collection schedules and provide adequate personal protective equipment. They should designate secure areas for on-site storage and improve transport methods for waste management. They should establish mechanisms for regular audits and assessments to measure compliance and identify areas for improvement. And lastly, the health facilities should create and enforce clear standardized guidelines for bio-based waste management tailored to healthcare facilities and waste management providers. Recommendations for humanitarian actors: they should regulate material and disposable equipment use to reduce waste generation. They should prioritize the procurement of biodegradable materials for personal protective equipment and shift away from single-use items. They should establish a filter systems for supplies and focus on needs-based donations to prevent the accumulation of excess and unusable items. They should emphasize product designed for recyclability and waste reduction to support sustainable practices within the humanitarian sector. They should conduct continuous training and educational campaigns to raise awareness about safe medical disposal among the communities. They should collaborate with private entities to align emergency waste management practices with the national regulations and provide technical support for bio-based solutions. They should partner with research institutions to promote environmentally friendly waste management practices and support policy creation through research and knowledge sharing. Recommendations for waste management service providers: they should partner with healthcare facilities to create customized waste management plans, ensure processes for waste segregation, collection, and disposal are efficient and comply with national regulations. They should invest in modern, environmentally friendly waste treatment technology such as autoclaves, microwaves, and advanced incinerators that suit local contexts and reduce environmental impact. They should extend service provision to remote and underserved areas by establishing decentralized waste collection and treatment hubs. They should initiate programs to raise awareness about waste management among healthcare workers, waste handlers, and the general public to foster better practices and understanding. They should collaborate with international partners and humanitarian organizations to leverage expertise and resources, improving waste management practices and efficiency. For the government, they should invest in building and upgrading waste management infrastructure, set aside a dedicated budget for waste management, including resources and personal protective equipment. They should invest in and promote the use of non-burn technologies such as microwaves and autoclaves to reduce the environmental impact. Should promote strategies for waste reduction and encourage the shift away from the single-use items to more sustainable alternatives such as biodegradable materials. They should recognize waste handlers as essential service providers, develop and implement comprehensive training programs for both healthcare workers and waste handlers to improve their skills and knowledge. They should introduce a digital waste tracking system to monitor waste from generation to disposal. This system will enhance accountability and provide valuable data on waste generation rates. They should investigate opportunities to repurpose non-infectious medical waste, explore the conversion of solid waste into bio-based products, and adopt decarbonization strategies to minimize final disposal. And lastly, the government should strengthen legislative policies on waste management, revise the existing frameworks to incorporate bio-based solutions, and support improved medical waste management practices. Thank you for listening. And now allow me to hand over to Pam Steele to take on moderation of the next sessions. Thank you.
Thank you very much, Helen, for that insightful presentation on waste management in field hospitals within humanitarian settings. I was just checking the chat box, and I think Alice will help us later to capture those questions, but I'm seeing very interesting stuff from Mahesh of Nepal regarding incinerators, that they are not the solution. I've seen some comments from Amro, who's asking about sustainability and efficiency of using autoclaves to pre-treat health waste. I've seen a comment from Nimao on needing suggestion on how to treat placenta pit when the pit is full. There's a lot to cover here, but let's now dive deeper into this critical topic with our esteemed panelists. We have a diverse group, as Safia shared, and I'm excited to explore their perspectives on the challenges and opportunities in managing medical waste, particularly in humanitarian setting. Let's begin with Stella Kamasir, who you were told is the Regional Director of Environment for Nyanza at the National Environment Management Authority, in short, NEMA. And Stella, you were listening keenly. There were issues around policy and regulation. From a regulatory perspective, what are the primary environmental challenges you have observed in medical waste management in Kisumu and in similar region, because we cover a very wide region of almost six counties within your region? Over to you, Stella.
Hi, everybody. Thank you for this. And it's interesting actually seeing the contributions and the experiences that we're receiving from the participants. Interesting also in the direction in which the process of waste management, particularly medical waste management, is taking in other countries. That's very interesting. I'll highlight what is happening in our scenario, more of the practice of what has been happening. That is not the ideal, we will say, but giving a snapshot of what's happening on the regulatory landscape and actually the environmental challenges we are facing with regard to medical waste management, particularly in this county, but largely also in the region. It also paints a picture across the country somehow, so it won't be very far from that. Now, the indicative data shows that only about 15% of our medical facilities have operational waste treatment systems. That's sad to say. So that also gives us the implication that that is the compliance level, which is very low, because where does it leave the rest of the 85%? And it's unfortunate that the medical waste treatment facilities are also limited and largely inefficient. Some of the hospitals have established, or let me say, fair to say, systems. Others who may not have what we will call efficient systems have outsourced the services to licensed incinerators. That's for incineration only, but on the larger picture, by law, we have the regulation and we have the environment. First, we have the Environmental Management and Coordination Act as the mother law, under which we have the regulations on waste management, which apply to medical facilities. We have air quality, we have water quality, and the ones for chemicals management is underway, it's being developed. But now what does that bring us to? As much as it is provided that every generator of the waste, that is by the act, that they have the responsibility to ensure that it is managed in a manner that's not detrimental to the environment. And the regulations also spell out the same. But that is not what is happening in many of the cases, as I gave you the indicative data. If we can start from the process of waste management, from generation to maybe disposal and treatment, there is limited infrastructure, as mentioned, and that is contributing in how waste is even segregated at source, how it is handled at source, because the regulations specify the period of time within which the waste has to be treated or gotten out of the facility to a place where it is treated. But then again, after segregation, is it being segregated in the right manner, in the right color coding? The color codes that are provided in the regulations are drawn from the WHO guidelines, and many of which the facilities may, of course, should adhere to. After separation, because separation is key to what follows next on the waste management chain and process. How is the waste stored at the facility for the temporary period that it should be stored there? Because it's provided that any waste that is not treated within 48 hours should at all times be stored below 0 degrees, so that it prevents the growth of microorganisms and bacteria and things like that before it is treated. Is this the scenario? Yes and no in some circumstances, or let us say in several of the circumstances. So the generators of our medical waste, the clinics, the dispensary, and our hospitals will generally be, they are generating these waste continually. But the continuation of the treatment process is also in question. The 15% of the hospitals that we are talking about, of the medical facilities that are compliant in, say, some sort of way, are the level 4 and level 5 hospitals that can be elaborated by a medical practitioner and in the page, in the webinar. And this cuts across both public and private facilities. Now, we've talked of segregation, storage, and the treatment process. There are limited facilities. If I can give an example, in Kisumu and in the Nyanza region, we have very few licensed incinerators. I think there are 2, 3. And the major one is located over 150 kilometers from Kisumu and from the neighboring counties, and it is handling waste for around 20 hospitals, 20 facilities in the region, which cuts across from even outside this region, from the western region, that is more than even that 150 kilometers. So if this waste has to be transported to that distance, it is also adding up to the other issue about, one, the financial costs related to transportation, but also an additional cost to the environment. That is an additional carbon footprint. That is, if it was to be treated, if it was to be treated on site, then that cost will come lower, both the carbon cost and also the financial cost. So we are adding those two elements with regard to having waste not being treated within the facility. And we understand that the principles of waste management require that there is that principle on proximity, which recommends that treatment and disposal of waste should take place as near as possible to the point of production, as is technically and environmentally possible, in order to minimize any risks involved in transport, but also just on logistical terms on what can happen. When we go to how the waste is also being treated in the facilities that have the treatment facilities. We've heard from the a survey that was carried out, we've had a few good practices, but majority of the other facilities will say they will be using burning chambers, a very bad practice, or even the incinerators are not operating as to the levels that are required because the regulation provides the minimum temperatures within which, say, for example, in an incineration, the minimum temperature should be 800 plus or minus 50 at most, but the minimum should be 800 degrees Celsius. And that also specifies, that regulation also specifies the retention time, and it specifies the temperature and the retention time. Unless they are we have very robust monitoring mechanisms to ensure that this is taking place, it will be hard to follow this through. There was a question I remember about if autoclaves are a sustainable way forward. Some of the facilities have autoclaves, but this serves not as the primary treatment system, but an initial treatment system to render as a sterilization process. It still requires another process thereafter on waste management, but it provides a leeway to extend the storage time within the facility. So generally we'll talk about on the challenges on the environmental front is, do we have sufficient facilities for treatment of waste? Do we have talk of resources, the personnel, the facilities, and also the expanse within which this can happen? Because if we are talking about humanitarian operations, then we need that almost every other facility has this capability so that in case of any emergencies, any facility can handle the waste that may come to its facility or may be near its facility. Thank you, Pam.
Pam, you are muted.
Sorry, thank you so much. Yeah, thank you, Stella, and I'm not done with you yet. It's clear that there are significant challenges on the ground. Some we see almost every day. Now, to build on that, how does NEMA, which is a National Environmental Management Agency, your agency, collaborate with healthcare facilities to ensure compliance with the environmental regulations? Because you saw in one of the slides, I think we saw a poster up that guidelines are available there, even on the notice boards or on the walls, but adherence is limited. How do your agency collaborate with healthcare facilities to ensure compliance with environmental regulations?
Now, I wish to point out that the relationship of the regulator and the regulated community, in this case, the medical facilities, will first begin even at the time of the establishment of the facility. That will require that the environmental impact assessment is done for a new facility. Of course, the environmental impact assessment in it will state how the potential impacts and how those impacts will be mitigated. And then now, within the environmental impact assessment report, in short, calling it EIA, they will have developed the environmental management plan, stating clearly on the actions required, the responsibilities, and even the resources that are required, which will basically even apply to what we will need in a medical waste management plan. Now, following that, annually, they are required that they do self-reporting through the environmental audit. The environmental audit also specifies the improvements they are making continually, and it is anticipated that in that process of self-reporting, they're also making strides on improvements along the way to reduce the risks that may be associated, that may have been pointed out, or any potential risks that may come. That is with self-reporting. But now, regarding how we monitor compliance as a relationship between us and the medical facilities, it's also the monitoring of the licenses that they are provided with. One is the license on waste management. With waste management, it's required that the facility, if they're not treating the waste within themselves, or even if they're treating the waste themselves or outsourcing the facility, there has to be an indication of, they have to document from the waste they generate, how it is being treated, in the quantities they're being treated in the separate streams of the waste. And if it is being transported outside the facility has to indicate to us when you're doing the control audit. That is our main point of it. When you're doing our control audit for the facilities or monitoring the implementation of the environmental management plan that is in their environmental audit, then those are the things we'll be looking at. If the waste is being transported outside the facility, there is a tracking document which indicates the type of waste to be transported, the volumes being transported, to be transported, where the waste is being transported to, and if that facility that the waste is being transported to is actually licensed. So that tracking process gives a sort of way and an integrity to ensure that waste does not get out of the way of that process. On air quality, it is the same thing. All our licenses, as a key thing, are conditional licenses. And the conditions of the license are to be adhered to at any given time. Even if there may be a challenge of close monitoring or close continuous monitoring, but out of their own accord and in the need of adhering to the provisions of the law, the conditions of the license are to be followed. Now, compliance to these conditions also means that they will not get the next license. I think this comes in more importantly even for entities which are doing the business of maybe incinerating waste, because it will mean that they may not continue doing the business if they are not complying to these provisions. If this being done, yes or no, it is here and there, but it has been a gradual improvement, which you have noted, and with close supervision and monitoring, we have seen improvement in some of the facilities. We report of good progress with some of the private facilities, and some of the public facilities are also reporting of the issue that they want to get into public-private partnerships in order to improve their own systems, which they may not be able to run within themselves. As at that, thank you.
Thank you very much, Stella. That's truly insightful. And thank you, Sophia, for reminding us that today's webinar is about 90 minutes long. Not every day do we get a policymaker from NEMA, National Environmental Management Agency, and there's so much to learn from Stella today. So Stella, if you don't mind, I'm conscious of the time I want to spare for the others. I would like to delve a little deeper. No, could you elaborate on the regulatory framework and guidelines that NEMA has in place for waste management in field hospitals? And are these plans to strengthen, are there plans to strengthen these regulations? That is one. And the last one is considering the unique dynamics in humanitarian settings, how do you think these frameworks could be adopted to address those specific challenges? Two-in-one questions. Over to you, Stella.
I wish to mention that the regulations do not specifically state the issue about field hospitals. It mentions medical facilities and medical waste. Actually, it mentions medical waste presumed now to be coming from medical facilities. Nothing specific on field hospitals, because this would be taken as either temporary, but also temporary in the sense of the short-term nature of the operations, if it is in a short-term operation, humanitarian operation, and if it is in a long-term operation, say, for example, in a refugee camp or something like that, it will be required that a long-term plan, an action plan is developed for that specific operation or for that particular camp, because then you'll be having key people responsible at that particular time. If this is going to be, let me just say if it's going to be included, our regulations are being reviewed currently to accommodate emerging issues also. Remembering the issue about COVID. During COVID time, the National Environment Management Authority developed guidelines specific for handling COVID-related waste. That would mean even for every specific hospital facility that was managing that, but also even for the general public, say, for example, in estates, housing settlements where there is a higher population, or even with public facilities, how they would have handled that. And that was intended to prevent any further spreading of the disease elsewhere through waste. This is if there is something I would say has been strong for within the regulatory framework, it's a consultative process which is also provided in our constitution, that public participation has to be done so as to get the views of all that are affected or have an interest. So this will be an interesting thing to have incorporated. But I want to acknowledge that there have been I would say, wide collaborative platforms also in handling humanitarian operations through the government processes of, if some of us may know, there was established what we call the disaster management committees at the national level, but also at the county levels, which has stakeholders cutting across the public sector, the private sector, public interest organizations, the NGOs, and even CBOs. And these have brought together stakeholders who will be able to be part of those responsible in handling any of the matters that may come up in a humanitarian operation. Thank you.
Thank you very much, Stella. I'm not asking you any more questions, but I'll follow you later after this. Now, let's now hear from Fred. Fred on watch, who Sophia introduced. Fred is the country director of health, public health and sanitation for Kisumu County, Kenya. Fred, what do you see as the key barriers to effective waste management in healthcare settings, and particularly in rural and undeserved areas of Kisumu County? Over to you.
Well, what we've seen basically as barriers are basically is about attitude on waste management, and this comes with what we call at the level of waste segregation, separation of waste become a problem, and you end up with mixed wastes. The other thing is that because we are not monitoring and there are no incentives on waste management, people tend to produce any waste anyhow. So having large bulk of waste, a lot of waste. And then even in terms of waste disposals, people tend not to care which type of waste. And sometimes you find some of the synthetic and plastic kind of, those are not biodegradable, being used, and the problem becomes more so with the Pampers and that kind of waste. There have been also skills gap. on even how to treat and manage waste. And most of the time, you also realize that there are also not enough incinerators, autoclave, and even microwave. Like for example, in we have one microwave, and that microwave would be the only one in the entire Western Kenya. And then, of course, we also have incinerator. Previously, we didn't have enough, but now we have built like every sub-county to have at least one centralized incinerator for us to collect waste and take there. Then sometimes we realize that PPEs, personal protective equipment for handling waste, becomes a problem, and because of inadequacy of the same, some of them tend to handle waste without even using the PPEs. Because of reduced funding, sometimes you realize that people do not care much on how to invest on waste. But then we have issues of course, incinerators, lack of proper support supervision, and then, of course, legislation. So you realize that we have legislation, but there are no clear guidelines and protocol on how to use this. We can have NEMA, we also have the Public Health Act, but there are what we call county-specific legislation and even waste management plan. So we came up with our environmental health and sanitation bill, and we are working on the regulations now, so that this defines what should be done, what should not be done. We also came up with the waste management plan because we realized that even the flow, even how to segregate and all this, and then how the flow of the waste and where they're supposed to go for disposal is a problem. So, and most of the time realize this, people are not prioritizing those who are handling waste. And in some cities and even semi-urban centers, you realize people are, even some ending up using street children, which is a violation of their rights to collect waste, because some of them will not even care to use personal protective equipment, and sometimes because they even don't have. Going back even to the health facilities, you realize some of them are having bins, some are lacking even bins, the color-coded bins. Some of them are having not properly closed, without not enclosed bins. They do not have tops, so they are open bins. And you know, this with flies and all that, and with infection, this is serious risk. So I think these are some of the things that make really, and lack of surveillance and monitor system for waste generation and even handling practices.
Mm-hmm. Thank you very much.
Mm-hmm. Yeah.
Thank you, Fred. Those are definitely very important points. But I want to follow on and ask you how the county addresses these barriers, and what kind of support do you feel is necessary from national or international partners to strengthen these efforts? You've been trying to do what you're doing by yourself. You know, what can you do to address this as a county, but what help do you also need from national and international?
Well, basically, what the county does to address this is to, number one, there's always, I said, inadequate funds. So this is to make sure that advocate for inclusion of the waste management in annual work plans, and also in sector plans, and then of course finally to our budgets for the same. Then and also even in county integrated development plans, we make sure that these are there, and then of course resource allocation specifically for waste management. Then the waste management plans, the county coming up with the waste management plans. And of course, we also have trying to sort the issue of lack of incinerators. I mentioned building on new incinerators, and sometimes there are frequent breakdown of the same. Then also to make sure that the incinerators are well maintained, and we can always have we can have them working. Then we also have now biodegradable and reusable products, championing for that. And that basically legislation, coming up with legislation to make sure that that waste management is taken into consideration. We also, as counties, come up with guidelines on how to manage waste and even waste management plan and treatment. There are issues of PPEs and that's need to be purchased by counties. And as well, there's what is called awareness sensitization of the public on waste management and basically health education. And we also have, we have designated waste disposal areas with ash pits. And of course, because sometimes when you transport waste, sometimes people do not even know where to dispose them, and they end up disposing them any other places. Counties also need to have collaborations with the research institutions, training, but even other private developers, and also sign MOUs with private health facilities to make sure that even the waste from the private health facilities are being managed and incinerated by counties if they do not have their own standalone incinerators. And there are private facilities, private companies who also collect waste. And this is also good, and the collaboration and partnership with them is very, very much important. The county also needs to enhance supervision and surveillance for waste management, making sure that there's monitoring waste generation, but then have incentives that can support, that can champion waste reduction in waste generation. Because if you produce less, then you get awarded a reward for generating less based on previous quantification. And also regular audits. When we have the healthcare waste management plan, or whichever waste management plan, then you also need to do audits quarterly and see whether it is working or not. Then, of course, training of plant operators and even those who are handling waste handlers also. So what we need in terms of support. Basically, number one, we talk about technical support. Sometimes in coming up with guidelines, the counties know these guidelines, and even coming up with legislation, and of course, also coming up with the tools for monitoring and doing surveillance on whether there's compliance to the work plans and guidelines. But then we also, because of lack of what I say, limited resources, coming into partnership to support some of the activities related to healthcare waste, whether it is for training, whether it is for sensitization, whether it is for purchase of PPEs. Yeah. So the kind of partnership that we are talking of. And of course, even in policy development to bridge the gap, supporting policy and advocacy. So sometimes when you want to come up with these policies, there is what you call goodwill, and you want to advocate and get goodwill from the legislators, those who make laws. These are basically members of county assembly and even members of national assembly. So sometimes you want to support them to do a joint co-creation and come up with a plan and even some policies that can help in proper waste management. Yeah.
Thank you very much for sharing that, Fred. One last question. Could you also speak about the role of local healthcare departments, especially in promoting safe waste management practices in healthcare facilities like field hospitals?
Well, the local, did you say local governments or?
Yes, I said local health departments.
Yes. In
promoting safe waste management, you are at a county level here. So
yes,
how do you work with them to make sure that they do the right things? Because perhaps, I mean, from the findings we saw that things are not as
Yes, yes. What we need to do as local health departments, number one is to come up with the legislations and regulations. And then we come up with the healthcare waste management plan. And then these ones, it means that this is shared across. We're also talking about waste receptacle and transport vehicles that can also collect this waste from different facilities and connect to where we have incinerators. Other than that, also we also do proper capacity building of staffs within these facilities, and of course sensitize and train them on waste management. And more so, if we have adequate PPEs, also to provide PPEs for them where necessary. But what is important is to make sure that we create awareness, and of course we advocate, do a lot of advocacy, so that they own up the process of waste management and make sure that their budget allocation, even from those facilities, even from those facilities on waste management. So I think basically also to help them do incineration from these facilities, support them in incineration. Sometimes they have microwaves. Sometimes we have microwaves and they don't have. Sometimes they have. So you probably do for them maintenance to support them. But those who do not have, we need to do MOUs for them so that we can manage waste for them and even incinerate, like for the ones for microwave. You know, microwaves use a lot of energy in terms of power. Electricity bills are so huge, and sometimes the spare parts of the breakdown is very expensive. So this needs support of the government, that we can have budgets to support this. But what we look for is to advocate for budget allocation, do procurement, and of course installation of these incinerators, capacity building of the waste handlers, and of course I talk about regulatory frameworks.
Thank you very, very much, Fred. Mahesh Nakarmi Nepal, I'm checking your postings there. You have quite a lot to say, so don't go away. We'll give you the opportunity. Let's now bring in the perspective of humanitarian organizations. And here we have Arasha Vina, who's a WASH manager at Medicines Sans Frontiers, MSF. Based on your experience, this is the question for you, that based on your experience with MSF, and I know we did share a few things there, but it's your opportunity to now speak to it. What are the most significant challenges you face in managing medical waste in field hospital settings, especially during emergency deployment? Arasha, thank you. Arasha?
Yes.
Yes, please.
Sorry,
Did
I was
you
a
get
bit
my
disconnected there. Yeah, maybe you can repeat your question.
I
was a bit
that.
disconnected.
The question
Yes.
I'm asking, based on your experience with MSF, what are the most significant challenges that you face in managing medical waste, particularly in field hospital settings during emergency deployment?
Thank you. Thank you. As we all are aware about MSF, our main mandate in all our interventions, our thoughts are always first on our patients and the staff through direct contact. And secondly, to minimize the impact of environmental, soil and water resources, and to reduce as much as possible the presence of contamination of vectors in our environment. When I talk about the challenges that we meet in emergency setup, I would say that the most challenging part of the interventions are always the software, as the hardware parts are not a challenge. The hardware parts, I may say, the construction of the waste areas, especially in emergency setups, we always go for a simple, very, very simple setups that we set up and they're operational within 1 or 2 days. That is, if we go to an emergency where there's totally no waste management facilities available. But now when it comes to the software part, it becomes challenging because training and sensitizing of the staff and even the people on ground takes a toll on us, mostly during emergency, because we are already in the risk duration and you do not have time to do the training and sensitizations. We try as much as possible to fix the time for all these trainings, but sometimes it becomes so hard. In order to ensure that the first step is, our first steps mostly in emergencies, we always ensure that we have the correct waste segregation. This is also a challenge because mostly in the setup, in the hospital setup for emergencies, we have tons and tons of patients walking in. At that moment, during an emergency, you have not deployed enough staff to take care of those patients or even to handle the waste. And most of the time you find that you have to do local hiring for the staff, for the support staff, and that means you will have to take your time to train the waste handlers. So when you employ these local staff and they're not aware of the dangers of non-segregation of waste and mismanagement of this waste during disposal, then it poses a very big threat to the community themselves, to the staff who are handling this waste, and to the patients, and to the entire community that is displaced. So it requires a lot of sensitizations and trainings to be able to maintain those good practices on the long term in a sustainable way. Then a second challenge is being able to treat and dispose of each category of waste appropriately. We do need to ensure that our waste operators wear appropriate PPEs. And all of you understand the emergency setup. Sometimes you pack and you forget one of the PPEs. You're already into an emergency setup. Waste is there and you have to segregate this waste and dispose it correctly. So most of the time it's, sometimes most of them ignore the PPE use because of lack of knowledge or education. Some mostly in the high temperature areas, they say the PPEs make them feel hot. So at times you train them to wear, but they take them off. And then another problem that we face is the respect of SOPs on waste treatment and disposal. You will bring an SOP, make it simpler for the local staff to understand because of the level of education, interaction with these SOPs. So you want to make them very simple for these staff to also understand and be able to follow these SOPs. But this becomes a challenge because you've just come into an emergency, you want a plug and play affair, but it takes you time for them to come and learn these SOPs and the protocols that you need to be followed during disposal and treatment of waste. Another major challenge that we have faced in several counties are space. You go to an emergency, you want to collaborate with the Ministry of Health, and the available spaces that they have within their facilities are not enough to accommodate installation of a burner or an incinerator for an emergency setup, because most of our emergency setups, we use burners, mostly high temperature burners that we fabricate and keep them in our e-prep stores. So when you do not get a space within the facility, it also drags time. And as I heard one of the panelists say, that storing this waste for a long time always causes contamination and all that. So it brings about this challenge of storage. You do not have a proper storage at that time of emergency. You do not have space to construct these burners, and you do not have like an enclosed, secluded area that will prevent the interaction between the people and the waste. So this also poses a very great challenge to us logistically, because that means then we have to improvise the storage facilities that will hold this waste until we get the spaces to construct these waste management areas. I would say another challenge that we might have met is the high volume of waste. In an emergency setup, a large volume of medical waste is generated, this can overwhelm the capacity of the waste management systems, increasing environmental contamination, because the higher the waste, the bigger the space for storage that you need. And therefore, if you go to a flood intervention, that means the wastewater will mix with this waste, flow downstream, and you do not know how much contamination will go downstream. So it poses an health risk downstream and to the entire community that has been displaced. Also, I would say inadequate infrastructure within our communities, mostly in the affected areas during emergencies. You find that there are places where we have our hospital setups which do not have any facilities in place. So that means when you go and you have generated waste, you do not have any facilities available within the surrounding hospitals or dispensaries that you can use to manage this waste. So that brings you to a standstill until you provide maybe a simple way of disposing this waste within the available facilities. Yeah, I would say those are major challenges that we face. And just to speak on the challenges, we might be speaking on the physical challenges, the hardware challenges, the softwares, but I would say waste management, waste segregation, and proper waste management and disposal lies on us as individuals, because it's not like it's not something very hard to do, but it's the way we approach things and our behavior towards the segregation, the policies, and the protocols that we have to follow. So if all partners will sit together and discuss and come up with one policy, because we have several policies regarding waste management aside the NEMA, so many organizations have their own inside policies. So if we can sit and have like one unity, I'll say a unity of guidelines and policies that will help us to deal with the segregation, then I think we'll be minimizing these challenges in the field.
Fascinating. Those are challenges certainly that resonate across many humanitarian contexts, Araja. But could you share any innovative practices or strategies that MSF has implemented to minimize the environmental impact of waste in these settings?
Okay, so as MSF, we are really trying our best to minimize the environmental impact of this waste. This is one of our objectives, to reduce the waste treated and dispose it responsibly. It is actually in our planetary health footprint reduction strategy that we have that runs up to 2030. On waste reduction, having waste management plan, we have a waste management plan, and we have a proper quantification of waste produced by our activities, be it in the waste houses, be it in the health facilities. Despite the areas that we always have a waste quantification, so that we know at the end of the day how much waste are we producing and how much have we treated and disposed of correctly, etc. To size the treatment and also the final disposal, these waste production quantification also assist. Being able to identify recycling solutions for the recyclable waste has also really assisted us in reduction of the waste. Removing disposal items and going for reusable, e.g., for example, part of the healthcare waste within the healthcare setting, aside the healthcare waste, we also get waste like water bottles, disposable plastics that patients walk in with. These are not medical waste, but in an intervention where we have, let's say, chronic illnesses, like, let me talk about COVID-19, we say, let's talk about mpox, we talk about hemorrhagic fevers. We will not want other patients to get into contact with such waste. For example, a water bottle that has been used by a patient who was infected. So we always classify this waste as one. And we have come up with plans and strategies to collect, disinfect, and take these plastic waste for recycling. Also, we have improved medical and logistics orders and stock management. We rationalize ordering and stock management to optimize for only the needs that we have within our mission. We reduce duplication of stock, reduction of waste, and in particularly, the hazardous waste, i.e. the expired pharmaceutical chemicals, let's say batteries, electronics, etc. On waste treatment and disposal, we have also had alternative solutions to incineration, i.e. we have the high heat thermal process that are used rather than the incinerators. When possible, we also do shredding and sterilization for landfill and for medical waste. We also use high temperature incinerators in small scale. High temperature incinerators are also used when needed. We use these high temperature incinerators when needed, not always. Waste management, outsourcing solid and liquid waste managements are also outsourced to competent partners. These are, for example, the wastewater from the septic tanks. We outsource partners who are licensed by NEMA and to properly dispose of this waste, because currently we are not in a capacity to dispose of the waste from the septic tanks and other wastewaters. On health-related hazards, particularly attention is paid to the management of related hazards waste, such that it is treated and disposed of in the responsible manner. These include the laboratory waste, biological, radiology waste, and also waste related to vector control. Water treatment, motorized, electronic, and other equipment of waste, for instance, are contracted to those recyclers that are licensed within the country to handle them. When you talk about mutualization, waste management infrastructures and services are mutualized with other sections of MSF where applicable, because we have several sections in the country. And you might find that one section has an advanced system than what we have. So we mutualize this so that we can have like a centralized waste management system area. And we work closely with the Poisons Board of Kenya to manage for example, the expired drugs, so that we do not dispose them to the environment. Yeah.
That's fascinating, Natasha. It's like I'm in a class learning, but I'm conscious of time. We have some 10 minutes to go. I want to wrap up this session, but one last question for you. Do you have specific examples, or even one where these strategies have effectively reduced waste or enhanced safety for health workers?
Yes, I have an example. I've not visited the field yet, but I've talked to my superiors who have visited this project of ours. We are using a Stariplus machine. It's a sterilization stroke shredding machine. We installed it in our project in Iraq for medical waste. It has no pollution emission. It is safer for healthcare workers. And we have got reports that the waste reduction was 90 to 100% with no pollution, no environmental effects, and it has really, really worked well. So that is an example that I would give, and I am proud of it. I would wish that we also have one in Kenya like that. And also in our project, for which we have organized the segregation and recyclable points of collection and processing of the recyclables, they are not overloading the incinerators with plastic papers, and this has reduced the waste treatment in our health facilities. Because when we send these recyclable materials back to the industries that can recycle, that means we are not going to put the non-healthcare waste into our incinerators or burners. This means there's less fume, since we work with incinerators and burners with certain kilograms of waste per hour of burning. So when we segregate these waste from the hospital through the doctors and our hygiene agents, this ensures that proper waste is transported to the waste area for final disposal. So this simply means that our incinerators are less burdened, and therefore there is no pollution and it does not affect the environment. And with the segregation, we also have storage areas with specific color codes. So even at the storage point, we do not mix this waste. This shows that we are segregating from the generation point to the storage point. And during the disposal, the burning stage, the incineration stage, we also have a register on how the incineration should be done. Hence, there's no mixing of the wet waste and the light waste. So therefore, in so many occasions, we've not had any occurrence or complaints of the smokes pollution within our environment, because where our projects are, we are always surrounded by refugees and beneficiaries staying around and other partners staying around where our waste areas are, but this has never affected them. So I would say this is one of the things that I'm proud to say that is effective in our fields. And we are glad to share the information, the designs of how to, construct such waste areas in order to ensure that the beneficiaries and the communities, including the environment, are safe from these pollutions and the effects that comes related to poor waste management.
Remarkable. Thank you so much for that, Arasha, and especially for the practical insight. And I was going to ask one last question to all the panelists, and I think you've answered yours by saying that there's need for unity, especially on the guidelines that can help us deal with waste management, and everyone having their own sort of guidelines, which only leads to confusion. But to the rest of our panelists, Stella and Fred, what opportunities do you see for collaboration among different stakeholders, whether it's NGOs or government agencies, healthcare facilities and communities, that can help us enhance management of waste management in humanitarian setting, and keep it short and sweet. Stella, I start with you.
Thank you. One of the main things that
Stella, we cannot hear you. Stella, can you please check to see if you were muted? You appear
I can hear you,
unmuted.
Sophia. She just dropped, and we also had a blackout here. There's big rains here, so maybe that has affected her. So yes, I don't know if she's able to continue. Stella, can you still continue? Okay, lights is back. Stella, can you still continue? We have some 5 minutes to finish off the webinar. So I just wanted to, but let me just say, Fred and Stella, if you're not able to speak, you can drop that answer to the chat box so that I spare these 5 minutes remaining to hear from the audience. We have been we're seeing some communication on the chat box, and it's at this point that I can hand over to Sophia to see if there are any questions that need to be answered, and we can take it up from there. But it's been a fascinating 90 minutes. I don't know how that time has flown so fast. It's been enlightening discussions, and I'm confident that we all gained some insights and ideas. So over to you, Sophia, if we can't get Stella to communicate. Stella, you're there. Thank you. Just one short one.
Yeah, as I indicated about one, the attitude with which we are carrying on with the issue of waste management, whose responsibility it is, and it is, let me say, my greater desire, also the desire of a regulatory agency, that there is a mind shift in how we are looking at the issue of waste, from the point of the generator? What is my responsibility and what am I carrying forward? When you look at the waste spectrum from reduction to reuse, where applicable, recycling, treatment, and even disposal. So our waste medical systems need to move to more resilient and cleaner systems, which are cognizant of the issues of climate change mitigation. So we should also now be looking at what could we be wasting, what we will call, are we wasting our waste? Because in every material, there is potent energy which we could be wasting if it is not recycled or it is reused. And it is possible that these systems are established if we look on the opportunities that lie ahead. So we are also looking at the possibilities. Is it necessary to have centralized systems which can run efficiently so that it doesn't have to be dispersed in different locations, but one which can be followed up easily? In Kenya, we wish it is coming now that the regulations on extended producer responsibility are coming up, and it is the requirement that every producer provides an inventory of the materials or the products that are introducing into the Kenyan market, and that they are also registered in an extended producer responsibility organization, which has a system to ensure that their waste products have a recycling channel. So it is possible that when we are shifting our systems even from incineration to, say, even autoclaving and other non-destructive systems, that there are ways to also recycle these waste and contribute in a better way in making our waste systems, waste management systems resilient and cleaner to our environment. Thank you.
Very much, Fred. In one word, what do you see for collaboration among different stakeholders?
Well, I think the first collaboration is to do with the media outlets for dissemination and creating awareness. And the other one is also in terms of public-private partnership for financing and resource allocation, and also learning institutions and other government agencies collaborations in terms of research and healthcare funding applications. And then we also have innovative waste management and best practice sharing. We can also partner with NGOs and civil societies to advocate for policy change and raise awareness on healthcare waste management.
Excellent. Thank you very much. And we've used 90 minutes on the dot. I'm sorry, Sophia, I have chewed it all, but we got some great insights here. I'm handing over to you to close the session. Thank you again. Thank you, our panelists.
Thank you very much, Pam, and want to express our sincere gratitude to Pam Steele of Pamela Steele Associates and our esteemed panelists today for this discussion through the Coalition System Strengthening Working Group on Medical Waste Management. We hope it's been useful for you. We will be sharing the recording as well as the slide deck so that you may share as well with your colleagues. Have a great rest of your day, and please keep an eye out for additional activities from the SSWG of the Coalition on topics related to the environment and supply chains. Thank you so much. Bye now.
Thank you. Bye-bye.
Thank you. Bye.